Hi everyone, I'm Sohail and welcome back to the Stroke Sense podcast, where we break down the latest news in stroke and neurology. Today I'm excited to have Dr. Aneesh Singhal here to talk about a concerning trend, strokes in young adults. Dr. Singhal, thanks so much for joining me today. Before we begin, could you tell us a little bit about your background and how you ended up in the field of neurology?
Of course, and thank you, Sohail, for the very generous and kind invitation. I'm a stroke physician at Mass General Hospital. I direct the MGH Comprehensive Stroke Center in Boston. I grew up in a family of physicians. My father was a neurologist, so I think it was in my blood. And during my training back home in India, in Mumbai, I was drawn towards neurology. I matched at Mass General Hospital, which was the best training program. And since then, I've completed stroke training because MGH is renowned for the advances in stroke care that is brought to the field.
That's amazing. So there's a common misconception that strokes only happen to older folks. But in the past 2 decades, there's been a rise in stroke across younger people as well. So when you first saw that data, what surprised you most about strokes in 18 to 50-year-olds?
Well, the how common was it? I think that's important. Yes, there's a rising frequency, but it's always been there. Just that we have failed as a medical profession to recognize the importance of stroke in young people. Every year in the United States, there are 800,000 new strokes. About 13 to 15% occur in individuals who are adults below the age of 50. That works out to about 100 to 125,000 strokes in young people, working people every year. In the span of this 15-minute podcast, at least three young people will have a new stroke. That's what struck me. Additionally, some of the rising incidence could be because of things like lack of attention to our diet, the rising drug use, other risk factors that have been sort of maybe ignored, and also the better detection because we have new fancy MRI scans that can show us strokes, which in the past with CAT scans or even before that were not so evident. So, yet another thing that's really surprised me is how often people who are young who have even a minor stroke that completely goes away or a transient symptom of a stroke that goes away, how often they remain unemployed. They have a three times higher rate of unemployment. And finally, very sobering, one fourth of patients who are young with a stroke actually pass away over the next 2 to 2.5 decades. That's a very sobering statistic.
So I'm a little bit curious on what you just said about the employment factor after a young person has a stroke. So is that because due to their stroke, they're now incapable of doing the work they used to?
So, this is actually people, as I said, with very minor symptoms or transient symptoms of a stroke, so they don't have any significant disability. They've recovered from a transient spell, but yet they're unable to go back to work. And we feel that it's because of unrecognized post stroke symptoms, such as living in fear, anxiety, maybe fatigue, maybe something else. But it really has a significant impact on their social and vocational life.
I see. So let's unpack dissection. So I've heard of them in high impact trauma, but you've seen them in everyday activities, right?
Right. Turns out that dissection is a medical term for a tear in the inner lining of an artery. In this case, the relevant arteries are the two carotid arteries in the front of the neck and the two vertebral arteries at the back of the neck. Now, it turns out that in young people who don't have heart disease or the effects of chronic high blood pressure or diabetes, their arteries are more compliant, they're more elastic. So they're more prone to getting these internal tears. And it accounts for one out of every five or six strokes in young people, this problem of arterial dissection. So it's a common cause of stroke in the young, and you can develop it through rather innocuous activities such as racquetball, just stretching your neck in an odd way. It's been reported with trumpet playing, with yoga, and a concern is that it's also been reported with chiropractic neck manipulation. And specifically, the chiropractors have a forward thrust maneuver of the neck, and that might predispose vertebral arteries to become torn, and that can sometimes lead to fatal strokes in the back of the brain.
So, how do you detect these tears? What kinds of imaging do you use?
Yeah, so you need to be vigilant. So, a good question. So, young people, if you start getting a headache, specifically one just above the eyebrow, which is different from prior headaches you might have had, look in the mirror if you see a droopy eyelid or a small pupil on one side or the other side. Those could be subtle markers of a stroke. Sometimes neck pain, muscular neck pain, as if you've had a neck spasm, could be the sign of a vertebral artery dissection. Then, of course, in the few who develop a complication, basically a stroke because of the dissection, you have the classic stroke symptoms. The acronym that is being used nationally to recognize a stroke is BFAST, BEFAST. Loss of balance would be loss of the eye, either vision or double vision, that's for the E. F is for facial asymmetry, signifying facial weakness. A is for weakness of the arm, it could also be leg, but the acronym says A. S is for speech, where you have trouble with language. You can't read, can't understand, can't speak, can't get words out, or start producing nonsensical speech. So be fast. The last T is really important. It's time. Time to call 911. So don't forget that. I think you can, apart from the subtle signs, the obvious stroke should never be missed.
So, another condition you study is reversible cerebral vasoconstriction syndrome, or RCVS. How do you explain that to a patient?
Well, this is a phenomenon that's been misunderstood for more than 70 years in the literature. When I was a resident, I came across a few patients who came in with sudden onset, very severe headaches. These were explosive. It's like a firecracker going off in your brain. Unforgettable pain, the worst pain imaginable. Then patients got better, but after a few hours or days, the pain came back with almost the same intensity. So, this sudden onset, severe explosive headache can result from many conditions like brain bleeds, aneurysm ruptures, clots in the vein or arteries. But if brain imaging rules out all of the above, then you're left with a diagnosis of thunderclap headache, like a clap of thunder. But either one or usually multiple thunderclap headaches is the hallmark of reversible cerebral vasoconstriction syndrome, or the acronym is RCVS. These bad headaches are often accompanied by narrowing of the brain arteries, multiple brain arteries. And if severe and progressive, about 30% of such patients can develop brain complications, such as bleeding on the surface of the brain, bleeding inside the substance of the brain, or ischemic strokes from reduced blood flow in the substance of the brain. The main thing to remember is bad headache, call 911. Make sure you don't have a brain bleed or something else. If you have three or four such, then entertain the diagnosis of RCVS. And be mindful that RCVS is horrific in pain, but everything goes away. People, the outcomes are excellent. That is why I've called it reversible vasoconstriction syndrome.
So, with such diverse causes, what does a complete workup look like for a young stroke patient?
Yeah, the main, when patients come in, especially young people, and by the way, it could be as simple as incessant vomiting. It's often mistaken to be gastroenteritis, but you do need to consider stroke, which is about twice as common as multiple sclerosis, and it's a very common condition worldwide. So, doctors in the emergency department, patients, caregivers should always consider stroke as one differential diagnosis. And if it makes sense, if it could be a stroke, get an immediate CAT scan. The second next step is to look at brain arteries. Stroke is an arterial problem of the brain. So, you have to examine closely with the CT angiogram or an MR angiogram, or sometimes a digital angiogram where they inject dye in the catheters. So you have to exonerate any problem with the arteries. If that's normal, then you look further down. If there's a clot that went up the artery, where did it come from? So we do a cardiac ultrasound, sometimes fancier cardiac imaging like a CT of the heart. And then we look at the blood. Is the blood at more propensity to developing blood clots? Is there an infection? So there's no limit. There's about 100 different tests you could do to ascertain the mechanism of stroke. You have to be pragmatic. And based upon the story and the risk factors, we modify the workup. So there's nothing that's known as a complete stroke workup, but the minimum stroke workup would be a CT, CTA, or MRI, MRA, a cardiac ultrasound, blood tests, and then rhythm monitoring of the heart to look for a condition called atrial fibrillation.
So now kind of moving on to what you're doing in current times, what sort of research are you involved in right now relative to this field?
Well, thank you for asking. I'll keep the answer brief. My field of interest is in what I call acute stroke neuroprotection. I'm trying to save brains from getting damaged shortly after the onset of stroke. And I'm showing, and I intend to show further, that simply breathing oxygen can mitigate the effects of a stroke because oxygen is a gas, it dissolves in the bloodstream once you breathe it, it then diffuses out into the brain substance. And if you start oxygen therapy very early, I've shown in numerous forms that it can reduce the impact of a stroke. The second thing is brain imaging. I've described many syndromes that result from identification of where the stroke lesion is. I'm also working with committees nationally and internationally to improve the recognition and management of stroke in young people. And finally, of course, my work on RCVS and other conditions that affect stroke in young people.
Yeah, the work you're doing right now is fascinating and seems very, very interesting. My final question for our young listeners, what proactive steps can they take?
First of all, listen to your mom. The American Heart Association has dumbed it down to life's essential eight, which is everything your mom tells you. Sleep well, don't drink excessively, don't smoke, including vaping, don't do drugs, exercise, eat healthy, in other words, eat green leafy vegetables, and cut out French fries and other fatty foods. A healthy lifestyle is paramount. I think that's what you could do. Now, you can't stop playing tennis or stop going, going on a travel. That can increase the risk of a stroke, but those are not things that we can prevent.
Dr. Singhal, thank you so much for your insights today and for shattering the myth that stroke is an older person's disease. It was truly an honor speaking with you today.
Thank you, Sohail. It's such a pleasure to be speaking to an audience of young people, and I commend you for your efforts to help us raise awareness.
Thank
Good
you.
day.
And to our listeners, please remember to subscribe to Stroke Sense, share this episode, and remember that stroke can strike to anyone at any age. So stay informed and stay vigilant.